Hello everyone, I'm Dr. Sethi and I'm going to be presenting on lens-induced glaucoma. So lens-induced glaucoma is a secondary glaucoma and it can be either an open angle glaucoma or an angle closure glaucoma. So let's look at what is the mechanism of IOP rise with the different kinds of open angle glaucomas. To start with, we have the Fecalolytic glaucoma, in which what happens is that within the cortex there is high molecular weight protein leak out of micropores that have formed in the anterior lens capsule due to the lens aging. And these exude out into the anterior chamber and are further phagocytosed by the macrophages, which then go and clog the trabecular meshwork and cause IOP spikes. The second type of open angle glaucoma is the lens particle glaucoma. There is either a breach in the anterior lens capsule and there is fluffy lens matter which exits out into the anterior chamber. This can either be due to an injury to the anterior lens capsule or after surgery, any retained lens matter, or after YAG capsulotomy. And this fluffy cortex goes and obstructs the trabecular meshwork. The third type is the anaphylactic glaucoma, which is actually a granulomatous inflammatory reaction directed against one's own lens antigens, which have been exposed. The type of angle closure glaucoma here is the phacomorphic glaucoma. As the lens fattens, there is an anterior shift of the iris lens diaphragm and there is pupillary block, resultant iris bombay, and a closure or narrowing of the anterior chamber angle, thereby causing obstruction to the outflow of the aqueous. A similar mechanism is the cause for a dislocated or subluxated lens, causing pupillary block because of the forward shift of the iris lens diaphragm and causing secondary angle closure glaucoma. Ectopia lentis or dislocated lenses can happen either due to Weil-Marchesani syndrome, Marfan syndrome, etc., or even after trauma. Lens-induced glaucoma is of very acute onset with very severe vision loss. There is ocular pain, ciliary congestion, there is corneal edema, the fixed pupil. There will be heavy anterior chamber cells and flare. There will be very high intraocular pressure, more than 40 millimeters of mercury. There will be a deep anterior chamber in open angle glaucomas like Fecalolytic glaucomas. There will be a shallow anterior chamber in phacomorphic glaucomas. Lens-induced glaucoma is essentially a clinical diagnosis. However, before surgery, a B scan is mandatory for you to understand whether there is any evident posterior segment pathology. Similar presentations also happen in other conditions which have to be kept in mind and ruled out. The primary management for these conditions to control the inflammation, number one, to control the intraocular pressure, number two, and pain relief for the patient, number three. To control the inflammation, you have to put the patients on hourly topical steroids. Oral steroids are also required if the inflammation is very intense, let's say cells above 3+. Topical anti-glaucoma medications have to be given except prostaglandin analogs, which have to be kept as the last resort in inflammatory glaucomas, and pilocarpine has to be avoided. Oral carbonic anhydrase inhibitors and very often hyperosmotic agents like mannitol also have to be given to control very high intraocular pressure. For pain, you have to give oral analgesics and sometimes cycloplegics to relieve ciliary spasm, which, however, is contraindicated in angle closure glaucomas. The definitive management for lens-induced glaucoma is, however, cataract surgery. Lens particle glaucoma and phacoanaphylaxis in pseudophakic eyes, actually irrigation aspiration of the lens fragments can be curative. For all other cases, closed globe surgeries like SICS and phaco is indicated. Open globe surgeries like ECC have a very high chance of expulsive choroidal hemorrhage, so they are best avoided. And the prognosis of this condition depends on how early the patient presents. For patients who are presenting late, sometimes combined trabeculectomy and cataract surgery is necessary to control the intraocular pressure. Now, challenges with cataract surgery are multiple in these cases. One, compromised cornea. You have a high chance of PCR because of thin capsules. There can be capsular extension, zonular weakness, dialysis. You can have dislocated lenses you have to deal with, small pupil. Low times in phacomorphic glaucomas, the anterior chamber is so shallow that doing the surgery becomes extremely difficult, for which a preoperative peripheral iridotomy can be done if the cornea is clear to relieve the pupillary block and iris bombay. Even if this is not adequate, sometimes a vitreous tap or a limited anterior vitrectomy may be necessary to deepen the anterior chamber for the sake of surgery. For a more holistic approach to the topic, and thank you very much for your patient listening.